Hello, everyone, and welcome to today's webinar, Update on HBV Testing and Treatment, today and tomorrow. I'm Susie Valdez of LabRoots, and I will be your moderator for today's event. Today's educational web seminar is presented by LabRoots and brought to you by DiaSorin. To learn more, visit them at diasorin.com. Now, we want to encourage you to participate today by submitting as many questions as you might have during the presentation. To do so, simply type them into the Ask a Question box and click Send. We'll answer as many questions as we have time for at the end of the presentation. You may also submit any technical issues here as well if you have any trouble seeing or hearing this presentation. Now, this webinar is educational and thus offers free continuing education credits. Please click on the continuing education window at the bottom of your screen to obtain those credits. Without further ado, I'd like to now welcome our speaker, Dr. Robert Gish, an Adjunct Professor of Medicine at the University of Nevada School of Medicine in Las Vegas and in Reno. Dr. Gish, welcome. You may now begin the presentation.
Greetings, I'm Dr. Robert Gish. I'm a hepatologist based in San Diego, and we're going to present today an update on hepatitis B testing and treatment, talking about today and tomorrow. I have my own consulting company. I work with Hepatitis B Foundation. I teach at Loma University and University of Nevada, as well as UCSD Skaggs School of Pharmacy. Disclosures are on my website, as well as many other resources. There's a tremendous medical need for testing and linkage to care for hepatitis B. It's one of the top causes of cirrhosis and liver cancer in the world, and we have 292 million people who are chronically infected with hepatitis B globally. In the US, we think it's 2.4 million. Risk-based screening for hepatitis B has failed. We are on a pathway, at least an attempt, to get to hepatitis B and C elimination by 2030. If you don't test everyone, you're not going to be able to find hepatitis B to proceed on the elimination pathway. The current standard of care in the US is to test all adults for hepatitis C and HIV. And of course, we've moved to universal testing and linkage to care and cure. For hepatitis B, which we'll talk about more, there is a functional cure, but there is a disease control. It results in excellent patient outcomes. There are large gaps in the screening and linkage to care. Think about this. We only have 1/3 of patients aware of their infection. And of those eligible for treatment, few are being treated. This means few on treatment, few being linked to care. Here are the risk-based advice for screening recommendations. On the left, the CDC. On the right, the United States Preventative Services Task Force. But what we've seen happen using risk-based screening for 20 years or more is a failure. We have few people, less than 1/3 are diagnosed. Hepatitis B Foundation, for the last 8 years, has taken the opposite approach. Test all adults. Make it simple. 3 tests, 3 blood tests, which we'll talk about shortly, for all adults, all pregnancies, and at-risk adolescents. Screening here, yes, we have geography. Yes, we have immigration. You could screen based on this, but how many people can remember these geographies, these countries? This is very difficult. I'm in the hepatitis B space, and I have difficult remembering this. Why not screen all adults? If we advocate for this, we'll be in alignment with the recent proclamation from President Biden's office that the U.S. should be part of the global elimination pathway. Very shortly, we believe there will be an advice to vaccinate all adults for hepatitis B, but you should have testing before vaccination, or at least incident 2. with 2/3 remaining undiagnosed. We need to do something different. A little bit more on this rationale to test all adults is not only can you diagnose hepatitis B, but you can also pick up on other types of liver disease and stage the liver disease. Perform a variety of specific tests that have to do with liver cancer risk. Do they need an endoscopy? Do they need to be followed more closely? And of course, linkage to antiviral therapy. Also behavior modification. We can get them to lose weight if they have fatty liver. Stop drinking alcohol if alcohol is a component of their liver disease. We can stop transmission. This is a liver disease, but it's also an infectious disease, and it's a systemic disease. We also need to test for hepatitis A because these adults should be immune to hepatitis A, and if not, vaccinated. There are a lot of barriers to screening and care. We have cultural and religious issues. We have stigma. There's stigma from the society basis. There are self-stigma. Many patients believe in traditional medicine or herbal or supplements as a way to manage their hepatitis B, which there's scant data that this actually has any improvement on liver health. There is racism, there is discrimination based on hepatitis B, as well as other viral and other infectious hepatitis and infectious diseases. There's a fear about stigma, about being discriminated against, about losing a job, about not being in a relationship. This is all wrapped up in this stigma process as well. We educate our patients. One of the major steps that we do in clinic once we identify somebody who's surface antigen positive is to go out and test all family members, all contacts, all intimate contacts. Of course, there's other issues about wound care, about household behavior and activities. But on the other side, there should not be discrimination. Hand-holding, kissing, sharing utensils, sharing glasses are all perfectly safe. And of course, we can stop transmission using condoms for sexual exposure prevention and harm reduction, needle exchanges for hepatitis B risk in that setting. Patient perspective, we need to be sensitive to this, but ultimately we want to help the patient and the community and the family. So it does take time for education, but we do have tests that are accurate. We do have treatments that are effective. All right, so we have a case. This is how do you stage somebody who's surface antigen positive? Think about this. Liver cancer risk biomarkers. Answer is yes. Alpha fetoprotein, part of that risk cancer triple biomarker. So we put that in as a second question that's really built into the first one. APRI and FIB4 help stage the fibrosis level. Elastography helps stage fibrosis, liver stiffness. Of course, you're going to have a surface antigen, core antibody, and anti-HBs. Screen triple panel, stage, risk assessment. Remember in your terminology that AST and ALT are not liver function tests. These are liver enzymes. Alkaline phosphatase and GGT are also liver enzymes, not liver function. The best liver function tests are bilirubin, albumin, and INR. And in fact, the direct bilirubin is the best of the best liver function. Let's go back to the triple panel. When you're assessing for hepatitis B, all patients should have hepatitis B surface antigen, core antibody, and surface antibody. Surface antigen equals infection, core antibody exposure, because core antibody means that that patient has cccDNA, a residual viral component in their liver. If the suspicion is correct, you're on the right pathway, you may have to look for occult hepatitis B is when they're surface antigen negative and hepatitis B DNA positive. Anti-HBs positivity equals immunity only if core antibody is negative. There is no natural immunity to hepatitis B. Once you're infected with hepatitis B, you're infected lifelong. It's extremely rare that somebody would actually get infected with hepatitis B, clear their liver of all virus, all cccDNA, and all integrated virus. This integrates Right after infection occurs, the virus starts integrating into the DNA. Reminds me of that movie Alien. This is interpretation of the hepatitis B serologic test. Somewhat complex grid, which I'm not going to go into in detail now since we've covered most of this, but this is a great printout to have or to carry on your electronic device, carry in your pocket, carry in your brain. Now we have this patient who we have identified as being hepatitis B surface antigen positive. What do we do next? You're going to check for hepatitis C, hepatitis A. You're going to check for Delta with antibody to Delta, HIV, renal function. You're not going to order blood tests right now for liver fibrosis since you've already done the APRI or FIB4. You already have other information, but that is an option for confusing patients, or you're confused about your patient. TSH, that's for the primary care providers. And double-stranded DNA, of course, that's not relevant here because that would be for autoimmune disease. Part 2, variety of tests are available to supplement what we just spoke about. Doppler ultrasound, chemistry, more advanced chemistry. Something that I like and I order on all my hepatitis B patients is quantitative hepatitis B surface antigen. I think this is very, very important. Part 3, alcohol history, renal function, bone health, pregnancy assessment, family testing. Rarely are we going to do a liver biopsy. But I do come back to these blood-based markers. I'm using something called Liver Fast from a company called Fibrognostics. FiberTest, FiberSure are old tests that I almost never use. Some are just around the corner are things called ELF or NIS4, other ways of assessing fibrosis. Let's go to best practices. Establish a clear follow-up plan, a callback system, a way to monitor. Blood tests every 6 months. Each time you meet with a patient, educate and re-educate, re-motivate that patient to continue compulsive follow-up and laboratory tests. I really like the word stop alcohol as opposed to avoid or limit, because nobody knows what their limits are, especially people with history of alcohol abuse, and assess for NASH and fatty liver. Best practices. Know your ABCs. Hepatitis A immunity. Hepatitis B triple panel. Hepatitis Delta if surface antigen positive. Hepatitis C and corona status. Know your ABCs. Stigma and discrimination can be discussed in a sensitive way with your patients. You may need an interpreter who's a sensitive individual. Clinic I work at in San Diego, we have 42 different languages available to us either directly or through a portal. So once you have a patient who's surface antigen positive, the guidelines talk about quantitating hepatitis B DNA. We covered that a little bit earlier. Checking liver enzymes. So DNA over 2,000, ALT elevated, strong propensity to treat. Assess fibrosis, significant fibrosis, that's F2 or higher. Very strong likelihood to treat. Currently, we have 3 medications that are first line: entecavir, tenofovir TDF, tenofovir TAF, which are 2 different prodrugs of tenofovir. That's 99.8% of the market. 0.2% is interferon. I've treated a number of patients with hepatitis B with interferon, but unfortunately, surface antigen loss, our goal, is rare even with interferon, and it's costly to the patient in terms of side effects as well. When to refer these patients to a specialist? Well, you have pregnancy, that should be managed. In that pregnancy, we're going to be testing the mother, finding out her viral level, considering treatment in those individuals if their viral load is over 200,000. Cirrhosis. Specialists need to think about endoscopy, compulsive follow-up for liver cancer surveillance, liver cancer first assessment. Of course, everybody gets a baseline ultrasound. Liver failure, serosities, is there encephalopathy? What does the liver function test look like? Then, of course, we're thinking about ALT flares. ALT increases at 5 times or more above the upper limits of normal or baseline. This can happen during treatment or if treatment is stopped. Delta hepatitis testing is simple. It's an antibody test. It's available through Quest right now, and we're trying to get that available through LabCorp. It really should be available through all the labs. I'm also working with a lab called BioReference, trying to get them up and running. Patients slip through the cracks. This is the CHECK study, chronic hepatitis cohort study. A number of different people have been using this CHECK program to look at patients inside different healthcare systems. So here you have hepatitis B patients, but only 78% had ALTs done per year. 37% had HBV DNA done once a year or more. Almost 20% had never had an HBV DNA test assessed. People with HBV and cirrhosis treatment should be 100%, but in this setting, only 56% had prescribed medicines. HBV DNA, extremely important part of assessing that patient after identifying surface antigen positivity. Only 54% had DNA annually. 35% were having it at our recommendation of twice a year. 11% had never had this HBV DNA done at all. All right, we have a challenge. We need your help. HCC screening and surveillance. Screening is the first test. Surveillance is ongoing testing. So here's the paradigm currently on the left, suppressive therapy. Entecavir, TDF, or TAF, you put them on it, the patients go DNA negative in most cases, and you keep them on the medicine indefinitely. I don't like forever because forever means forever, and we have many new medicines coming. So indefinite is a softer term, a little less threatening. Future is going to be heading towards a functional cure instead of 0 to 10%. We're trying to get to 40% with our next treatment options. The ultimate goal is S antigen loss off treatment. DNA needs to be suppressed to undetectable. We don't accept any level of replication, and sometimes 2 or 3% may require 2 drugs or switching drugs. But really, we want to get to a finite course of treatment, not indefinite as we are today. Patients are concerned about taking pills every day, but they take vitamins every day. They take herbal remedies every day. They can definitely take one of these tablets of these 3 different medicines. And the side effects are really rare. Entecavir, almost no side effects. Of course, there are remote chances of lactic acidosis with that in really sick patients in the hospital. And treatment eligibility might mean even insurance status. And of course, the patient's motivation. So when we're thinking about treating patients, we think about what are the risk factors for progression, and we look at those and try to use those to decide who to treat. But you can see how complicated this gets. Age, gender, DNA level, ALT, fibrosis status, how high are the AST and ALT? Is there liver iron? Is there liver fat? Do they have HIV? Do they have Delta hepatitis? What's their smoking status? Family history for liver cancer. All going to come into this formula to try to move somebody to treatment. So if I find one of these things wrong, I'm very likely to treat them. Of course, you might find 5 or 10, then you have really good data to further motivate that patient to stay on treatment. There are fears, fear of being diagnosed with liver cancer or dying prematurely or being a burden to the family. There are barriers about getting callbacks, the patient remembering your office or our staff or a doctor's or provider's office calling the patient back because they forget. So callback systems are very well. Many of these patients feel good. Why do they need treatment if they feel good? There's a lot of sort of background self-treatment, self-medication that occurs. So let's talk about the 6 pillars of management of hepatitis B. Number 1, test all adults. Of course, you can do risk-based, but we believe that fails. Core antibody, educate the patient if their core antibody alone about the risk of reactivation with chemo, with HIV medicines, with hepatitis C medications. All these things can lead to flares and reactivation. Vaccinate all adults who are triple negative. Remember, ALT healthy for men is less than 35, for women less than 25. There's a difference in ALT, AST, alkaline phosphatase, and GGT by gender. It's really interesting. S antigen loss is your ultimate goal, so I quantitate hepatitis B surface antigen in all of my patients annually. Are they clearing on their own? Are they clearing on treatment? Or if they're not clearing, what else can we do? Here's more on quantitative S antigen. It helps establish the state or phase of disease. Higher levels are associated with liver cancer. Higher levels are with a decreased probability of viral control or clearance. It does have some relationship to the response to nucleoside or nucleotide analogs. There is stronger evidence about response to interferon. Quantitative S antigen also correlates with risk of transmission. If you have a mother whose viral load is, say, 600, but the surface antigen quant is 10,000, you've got a big problem. And this type of scenario does occur. So let's talk about Delta hepatitis for a moment. Worldwide, we think there's 15 to 20 million people. And in the US, we think there's 150,000 with Delta. And it's about a 70% mortality rate in less than 20 years, maybe closer to 10 years. Very few patients who are surface antigen positive have been screened. Fewer diagnosed because the screening test doesn't mean someone talks to them about it. The management, it means more aggressive interventions, including interferon, and that's where the treatment is just a few percent. This we hope will change with our advocacy. Point of care, there are tests around the world for surface antigen and a few more that actually look at core and surface antibody. Very important. There's other point of care tests, including point of care for hepatitis B DNA quantification that takes 20 minutes and is relatively inexpensive in the $20 to $30 range. So there are things that are coming. Hopefully wherever you are, you're going to be hearing about these point of care tests and have those phased into local algorithms and protocols. So in summary, let's walk through this. Hepatitis B vaccination is safe and effective. We have a really new, good hepatitis B vaccine called HEPLISAV-B. It's 2 doses, much better compliance and adherence because you don't have 3 doses. And the 2 doses are within 4 weeks of each other typically. And much higher titers and protective titers, especially in diabetics and other people that are in a higher risk group. Vaccine coverage in children, there's over 1,000 children in the U.S. that are infected with hepatitis B lifelong because the mother and the baby were not properly managed in that perinatal period. So if the mother has a high HBV DNA, we treat her with tenofovir, TDF, during the last trimester to bring the viral load down so the baby doesn't get infected, and it's quite effective. If you combine tenofovir with a sub-Q injection, which would be in her case, or a case, try to have it in the arm. But those would be an important place for talking about application of vaccination. At birth, newborns should get the vaccine within 2 hours. A lot of the guidelines say 24 hours, but if you use 2 hours, it's very likely the the patient wouldn't need hepatitis B immune globulin. So we talked about hepatitis B vaccination, we talked about hepatitis A vaccination. Of course, these are very, very important. There's been a big impact of hepatitis B testing, treatment, and vaccination from COVID-19. This is what the health departments are saying in terms of a year previously. Unfortunately, this provider outreach on the top, 83% is okay. Community outreach at 82%. But look at hepatitis A vaccination, way down. Hepatitis C, linkage to care, very far down. Stopping surveillance testing. Hepatitis A outbreak response, terrible. San Diego's a big problem with hepatitis A epidemic. So I think we are at a wrap. I wanted to move to Q&A. I want to thank the LabRoots team for helping with this, the Diasorin team for helping to set this up, James and Ashley have been great to work with.
And we'll call that a wrap.
We look forward to our Q&A.
Thank you so much, Dr. Gish, for your presentation. We will now begin the live Q&A portion of the webinar. And if you have any questions you'd like to ask, please do so now. Just click on that Ask a Question box located on the left of your screen, and we'll answer as many questions as we have time for. So let's take a look at what our questions are coming already in. Dr. Gish, is HBV testing a true need based on the low prevalence of HBV in the US? Or globally there are HBV tests available, but in the US there is not an FDA approved option?
Great question, Michelle. I'd like to clarify approval. As you know, in the United States, there's multiple ways to access testing, including what are called LDTs and CLIA-approved testing, as well as what we call FDA clearance for diagnostics. And fortunately, there are Delta tests that are available in the U.S. through reference laboratories, currently through Quest specifically. I know LabCorp has things in development for Delta antibody and Delta PCR. Even without the FDA clearance, most people should have access to antibody testing and then reflex the PCR testing. So I think that's very, very helpful. And yes, I believe that our Hepatitis B Foundation advice is that everybody who is surface antigen positive should be screened for Delta with a Delta antibody test. And the Delta prevalence in the U.S. runs around 6 to 7% in the surface antigen positive population. And because it's 70% fatal, progressive cancer, death, transplant, we believe that the Hepatitis B Foundation is simple, just to make sure every Hepatitis B patient has a Delta test in their chart. We think it's much more effective than risk-based screening, which, as you know, failed for HIV, failed for Hepatitis C, it failed for Hepatitis B. So why do our advisory panels keep talking about risk-based testing when the peer-reviewed evidence is that it has failed? So test all is the final statement.
Thank you so much. And Dr. Gish, what is your recommended algorithm for testing hepatitis Delta? Would you also use IgM?
So the IgM test for Delta should only be used in somebody who presents with very clear acute viral hepatitis. I think that's an important point. I don't use IgM for general screening. It should be total antibody, which basically is going to screen for IgG. I do think there's some sensitivity for IgM in the total antibody. And we think that that antibody test is around 95% sensitive, that it might miss Delta 5% of the time, although that's still being worked out. So it's a very good screening test.
Thank you so much. Now, first I want to thank our audience for these great questions coming in. Dr. Gish, do you believe increased screening for hepatitis B would have an overall health economic benefit for providers and or laboratorians?
So we have to think about health benefit, health cost. If somebody is Delta infected with a 70% chance of dying of cirrhosis, needing a transplant, developing cancer, a test that's in the $20 to $50 range is phenomenally cost effective and probably even cost savings. So from simple modeling, this is the right thing to do. We're on a path to eliminating viral hepatitis in the world with WHO, with the recent proclamation from President Biden, with the CDC buy-in on the elimination program. And if you don't test, you can't eliminate. Along those lines, people say, well, if there's no treatment, then why would you test? Well, first off, treatment doesn't necessarily mean an injection or a pill.
Treatment means advice about lifestyle, decreasing infectivity to other people, including decreasing or stopping alcohol intake, or if they have fatty liver, managing metabolic syndrome, lifestyle issues. So treatment is a really broad term, and we really need not to focus on pills or injections as the only form of treatment. And there is a treatment today for Delta. It's interferon therapy. It's available. There's peer-reviewed publications that cover this and clearly show a cure rate, meaning a maintained viral negativity. I'm not going to use the word cure in the big sense, but maintaining the virus as negative in the 15 to 20% of patients. And another subset of patients have a reset in their viral load, their DNA, hepatitis Delta RNA test. So when the RNA gets reset by 2 logs or more down, outcomes are better. That's been shown also in a paper by Patricia Farsi. I think that was the one in New England Journal of Medicine. So there's lots we can do. Also, if you have somebody with Delta, you're going to manage them and monitor them more frequently than a hepatitis B patient. So Delta testing means linkage to care. Good care is a variety of different interventions. Treatment is a variety of different interventions.
Thank you so much. And it looks like we have one more question coming in from our audience. The CDC described patients with SAG negative and anti-HBC positive and anti-HB as positive to be immune due to HBV infections. Do you think that the description is misleading, considering that patients can have HBV reactivation?
That is a fantastic question, and what you're reading is some very old information from the CDC website. If you're finding that currently, I would need to find the web link and go back to the CDC and have them hopefully delete that or archive that. When you're core positive, it means exposure. Core antibody positive means that there's CCC DNA, residual virus in the liver. When there's surface antibody positive with core, that's not natural immunity. That's not immune due to hepatitis B infection. You're exactly correct. This is the wrong term. We call it immune control. So the higher the surface antibody positivity in somebody who's core positive just means that the immune system has better control of the hepatitis B infection and a lower risk of reactivation. So core only, that's highest risk for reactivation, and can also define occult hepatitis B. Core plus surface, the higher the surface antibody titer, the lower the risk of reactivation. So let's use the word immune control, get rid of the word natural immunity, which is an oxymoron, or immune due to Hep B infection. And if you find that somewhere, shoot me the link by email, and I will go to the source and have that corrected. Fantastic point.
Dr. Gish, I want to thank you for your presentation today. Would you like to provide any closing remarks for our audience?
There's another question in the chat box about quantitative S antigen, and that is available. There's a Quant S available both through Quest and LabCorp now. And I order that and have been ordering that on all of my patients dating back 3 years or 4 years from Quest, and then this year from LabCorp. So quantitative S antigen, I believe, is the standard of care once a year in all of your hepatitis B patients, whether they're on or off treatment. I think you're going to find the guidelines are going to be updated this year from EASL concerning this. I just talked to Pietro Lampertico about that, who wrote the guidelines. And then hopefully AASLD will update theirs and be very specific. You have to think there's over 200 articles in the publication, in the literature, about how to use quantitative surface antigen to help profile patients' clinical status, their infectivity, the risk for liver cancer, on-treatment response. Are they clearing hepatitis B naturally? There's some relationship to infectivity that partners with HBV DNA levels. So yes, you can order it today. I strongly recommend you order that and have that on your B patients and track trajectory of surface antigen status. And there's one more question, Michelle, if I can jump to the one about anti-HBs for protection. So this is a great question. So anti-HBs alone, if positive, means that that person's been vaccinated. There's no way to develop surface antibody without having exposure or without having vaccine. Now, there's a little bit of variation in the literature about what that level of protection is, but I like to use the number 15 IUs. So if it's measurable at 15 IUs or above, that person's had a vaccine response. But I'd like to highlight that all of the vaccines are both B-cell vaccines and T-cell vaccines. So when you give hepatitis B vaccination, whether it be the 3-dose Endurex or 3-dose Recombavax or the 2-dose Heplisav-B, which is what I use in my practice, you're stimulating T-cell and B-cells. We can't measure the T-cell immunity clinically, but in research, we have extensive data on T-cell responses. So when people get the hepatitis B vaccine, 2 or 3 doses, they don't even need to check a surface antibody level, except in very special patients. Who is special in this setting? Be dialysis patients, HIV patients, or healthcare workers with extensive blood exposure. Even then, we're not really sure that checking helps that patient, but it is part of the protocol today. And those very narrow populations are the only groups that need boosters. So when you vaccinate with 2 doses, you vaccinate with 3 doses, whichever vaccine you're using, you do not need to check a titer. They're vaccinated for life, according to what we know, and for life means protection goes out now 30 years, according to published data. Only people you need to retest would be babies born to a mom with hepatitis B, and then these other few special patient populations. And that's covered very well at the CDC website. They've done a really good job updating terminology, updating advice. I had some differences with the CDC in the past, and I communicated that to leadership there. They really brought their website up to current definitions of these tests, what they mean, what to do about vaccine. The CDC is doing a fantastic job, just like they are with our COVID epidemic.
Dr. Gish, thank you so much for your time today and for your important research. I also want to thank LabRoots and our sponsor, Diasorin, for underwriting today's educational webcast. And before we go, I want to thank you, audience, for joining us today and for your interesting questions we did not have time for today, and those submitted during the on-demand period will be addressed by our speaker via the contact information that you provided during registration. And this webcast can be viewed on demand. LabRoots will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's live event. Until next time, take care, everyone. Stay healthy. Bye-bye.